Okay, thanks, Susan, and thanks to everyone for joining. Today, it gives me pleasure to introduce Peter Tanuseputro. I hope I'm pronouncing that correctly.
Perfect.
I came across some of his research in CMAJ earlier this year. I thought it was quite provocative, particularly in the local provincial context. So Peter comes to us, he's an associate professor in the Division of Palliative Care at the University of Ottawa. He has training in public health and preventative medicine from the University of Toronto. He practices family medicine in the community with a focus on palliative home visits. And his research focuses on using linked health admin data to develop population perspectives on healthcare use and outcomes associated with aging and end of life in Ontario. And he's actually a Tier 2 clinical research chair in palliative care and predictive analytics at U of Ottawa. So without further ado, I'll pass the mic to Peter to hear what he has to say.
Thanks, Ben. And thank you for the kind invite to present. I see that there's probably, I don't know, maybe around 20 people, but generally I like to keep the talks pretty interactive, if that's okay. So if people have burning questions, Ben, feel free to stop me at any time. Okay, I feel that sometimes people go on and on and on, and people have questions that that could make the talk a bit clearer. So if you have any questions, again, just interrupt me. So yeah, and thank you for the introduction. So again, I'm a public health physician. I'm a health services researcher, 80% research. As Ben said, I practice family medicine in the community, but this was my side gig. My partner, my wife, is a family doctor, and essentially I'm her locum, and I give her a day off, and that's why I practice family medicine. But this is my passion to conduct health services research. And I'm going to talk about our program of research that looks at linguistic minorities in Ontario and see how linguistic minorities in Ontario, obviously Francophones are the linguistic minorities, but there are also a lot of other, obviously, diverse ethnic cultural backgrounds of people speaking different languages. And we explore what are the differences in care that's being delivered to these individuals. And more importantly, we have the ability in Ontario to look at, and I'll show you how we did it, so you can potentially replicate it in Quebec, but to look at how disparities in the language of the spoken by the patient and the language spoken by the care provider, in this case physicians, how that concordance or discordance impacts healthcare outcomes. And the CMHA paper that Ben talked about, I'll go over that, but the results are quite striking. There's large differences in outcomes. If you're a physician, never mind all the other healthcare providers, but just a physician speaks the same language as you. So that's just an overview. Let me just minimize this. So this is part of our team in Ontario that's looking again at linguistic minorities. We're based out of this group is based out of ISM, Institut Safar du Montfort, or du Safar Montfort, and is based out of Montfort Hospital, which is one of the hospitals in Ontario that's designated as a French facility. So it provides care in French to Francophones in the area. Just some other team members, I'm not going to go through it, but research is a team sport. So the things I'm presenting to you, obviously is a product of a lot of people's hard work. And I just want to give you a brief overview. If you're interested in some of the areas of what we do a diverse set of programs of research. Linguistic minorities is up here. We look at the COVID response. I have a chair in predictive analytics and palliative care. That's a big part of our programs of research. Physician health. So we actually married our programs of research in physician health and linguistic minorities. And I'll show you how we took advantage of the health databases or the databases of physicians to be able to identify the languages that physicians speak so that we can look at language concordance in the care that they provide. And I'll show you exactly how we do that. And we are trying to replicate what we're doing with this work in other provinces as well. Okay, so I thought I'd start with where I came from. So I was born in Surabaya, Indonesia. my last name, I don't know if anyone picked up on that, is an Indonesian last name. And I lived in a pretty small town, Mojokerto, which looks like this. This actually looks more developed than I remember it. But essentially, we came from pretty humble, humble background, and we immigrated to the GTA, to Toronto in 1986. And I was 8 years old at that time. And my parents, my older brother, my sister, my younger sister, none of us knew how to speak English. So we were, my parents, I think, took some classes, in English before they came, but essentially we had no proficiency in English. And so coming to Canada, it was quite a shock, and things like accessing healthcare, was quite foreign to us. So obviously, since then, we've moved to Ottawa. That's my daughter Ava, and we've settled in nicely in Ottawa. And there she is again. I just like to personalize these kind of talks. But here's what I'm going to talk about. So today I'm going to talk about this jigsaw of language and healthcare delivery. And there are different components that we look at in our program of research. Obviously, we look at the language of the patient, and I'll tell you how we do that. We look at the facility language. So I told you MAW4 is a French designated facility. So we look at, for example, Anglophones, Francophones receiving care in MAW4, or Anglophones, Francophones receiving care in Toronto General Hospital in Toronto, where I trained. Did their outcomes change or differ? So we look at the facility language. That includes hospitals, but it also includes things like nursing homes. So we have the ability to look at, okay, ethnic, if you're an ethnic minority, you're Chinese, for example. So my ethnic background is Chinese. So if I'm Chinese and I enter a nursing home that speaks English, how does that impact my care? Or, compared to, for example, if I'm Chinese and I was able to enter a nursing home that catered to Chinese individuals, and there are several of them in the Greater Toronto area, in the GTA. How does that language barrier, how does that language of the home, impact the care that you receive in there? And I'll show you some statistics on that as well. I talked about this already, the language of the provider. We're looking at, so far, the language of physicians. We've linked essentially registry data from the CPSO, the College of Physicians and Surgeons of Ontario, into our databases at ICS, and I'll talk to you about this, to be able to show how the proficiency of the language of the physician providing care to that patient who speaks a different language or the same language, how that impacts outcomes. And again, at the heart of this is this idea of language concordance or discordance based on the language of the provider, but also looking at the language of the facility. And essentially, I think there's a lot of, we're not the first ones to do this research. There's been a lot of research to suggest that, language discordant care impacts outcomes. But, I would bet that we were one of the first to show this at a population level, non-biased, across different healthcare settings. And we use the big data at ICS in Ontario, but this could be done, I bet you, in Quebec or other provinces as well. Okay, Ben, is that clear so far?
Yeah, crystal clear.
Okay, perfect. Okay, so language is not binary. It's not yes, no. There's lots of different concepts of language. There's Losh language, most often spoken at home. There's mother tongue. There's preferred language, language used at work. So the first thing we did in this program of research is take a stock at our databases in Ontario to see how a language variable is collected across the data sets at ICS. So ICS essentially is, I don't know if people are familiar, but it's a data custodian that links all the data from different data sources, the Ministry of Health, the CAI data sources for hospitalizations, long-term care, home care, and it's all linked at ICS. I know there's some equivalency in Manitoba and other provinces. I know Quebec has the ability, and we work with Quebec partners and scientists as well. I know there's ability to do that in Quebec as well, although not perhaps as organized. But we look at the first thing we did was look at all the language variables that are captured And you can get a sense here, out of the 91 databases at ICS, we captured 25 of them that actually had a language variable to show what the language of the patient is. And the most frequent variables are mother tongue and primary language spoken at home, and official Canadian language, obviously English or French.
Peter, can I ask you what data sets had the language variable? Because typically health administrative data doesn't. In Quebec, our birth registry data does have language spoken at home, but in terms of linkage to our health admin data, we don't necessarily have it. So I'd love to hear what you have.
Yeah, we had to be creative. So I forget if Quebec participates in the CCHS, the Canadian Community Health Survey. I think it probably does, right?
It does. It just makes it hard for us on every level, but go ahead.
Okay.
Yeah.
So that's one of the data sources we look at. And, it's a challenge, there's so the other databases that we've taken advantage and same with, our CMHA paper is actually home care and long-term care data. The problem is I know Quebec doesn't use the INTRI tools, the resident assessment instrument tools, but we have that at a population level for home care recipients and for all long-term care residents, and that's what we use. And we have it in OMERS, which is our mental health database. And there's other databases that we haven't exploited, but we started here because they're frail individuals, people in home care and long-term care. So it's nice to justify, and it's at a population level, and we have large sample sizes. But I think if I were in your shoes and you're interested in this, maybe you've done this already, but I would just like what we did, take stock at every database that's available. Some of them are going to be impossible to link, like census, so like StatsCan will never let you link that. But are there smaller databases that are population-based or survey-based that you can potentially link, right? And we've had to be creative, because some of these databases normally people don't look at in terms of language.
Yeah, actually, I was going to say StatsCan does let you link through the CanCheck cohort. So, and that is one way of doing it. So it would be CanCheck with discharge abstracts. Okay.
Yeah. No, I think you have to be creative here, because not even Kai Hayes discharge abstract hospitalizations, even that doesn't capture in language quite prominently. But I think as I'm going to show you, it's really important, right? In terms of outcomes. And I think the first step is to take stock of what's available, and then with studies like ours, make the case that it should be included in studies and in databases, and then slowly work towards linkages, right? So I don't know the Quebec data milieu as well as I should, but I'm happy to brainstorm in the future. Okay, so I'm going to go on. So again, we have the luxury in Ontario of having this home care and long-term care data. And the first thing we did was identify the language variables in the right variables in the home care and long-term care data, and see how it mapped to the diverse and rich language variables in the CCHS, the Canadian Community Health Survey. I mean, just a graphic, but essentially, the short of it is that the long-term care CCRS and home care RIHC data, the language most correlates to language often spoken at home. And that kind of makes sense, because these trained assessors, they go into a home and they're supposed to observe what kind of what language they converse in with their family members when they do these RI assessments. I'm not sure in Quebec if I mean, you must have some equivalent assessment in home care and long-term care. And I'm guessing language would be part of it, but again, I think it would take some exploration. Okay, and then I'm not going to go through this, but obviously we look at the sensitivity, specificity, PPV, NPV, but just to say that any misclassification that we have probably attenuates the impacts that we have in our studies. But it's not perfect, but we think it's reasonably okay. But I can send you these slides if people are interested. But that's the first thing we did, validate, quote unquote, the linguistic variable. And then the next thing we did is we map out a whole bunch of outcomes that we were interested in. So we have here a linguistic group, language of service provided, language concordance. That's our exposures. And we mapped out a bunch of outcomes, mainly in end-of-life palliative care, because that's what I do, but also because these are frail individuals and everyone's kind of looking at what happens to them when they're declining. And then we're looking at across different disease health conditions to see if their health status differs, and obviously mortality as well. And we have a bunch of data sources that we use in Ontario. These are sort of the buckets for long-term care and home care recipients of outcomes that we look at. End of life in palliative care. So we look at healthcare use, cost of care, location of death. We use quality and safety of care indicators, and I'll talk to you about this in our CMHA paper. But we have quality indicators in falls, pain, physical restriction, patient harms. So CAIHI has created this list of patient harms in hospital, things that shouldn't have happened or that are care sensitive. So infections, falls, medication errors, and we have a list of them that we explored as well. And obviously, like the hard outcomes, ED visits, hospitalizations, and mortality. For home care, same thing. We look at across those sort of outcomes. But essentially now we have exposure, language of the patient, language of the facility, and language concordance. And then we look at these outcomes, okay? And then we just, we're just gonna pump out the studies. So this was our first study. I know it's busy. I'm gonna point you to a couple numbers. That's all you need to look at. So this is Anglophones here. I think hopefully you can see my arrow. Francophones on this column, and then all decedents. So this is a decedent cohort of people who died in Ontario. And we looked at first, what is the healthcare delivered to them in the last year of life? And the two numbers I'm gonna point out between Anglophones and Francophones are in long-term care and home care. So in long-term care, 37% of Anglophones receive long-term care or reside in long-term care prior to death, while 47% of Francophones, 47.6%. So many more Francophones end up in nursing homes compared to Anglophones. And when we look at the services that are provided in the community, it's a flip side. So in home care, 70% of Anglophones receive home care, only 71% of Francophones receive home care. So Francophones are receiving, as a linguistic minority, less home care and more care in residential settings. We looked at here location of death. So I believe this is odds of dying in hospital. And we can tell here, where's the language variable here, that Francophones are 18% or have 18% higher odds of dying in hospital compared to Anglophones when adjusted for a bunch of variables. So this was just our first foray, just describe the healthcare that's being provided for these individuals in long-term care and see where they die. And so we saw initial differences there. So I'm gonna gradually go from descriptive to more evaluative studies, okay? So that's just a descriptive study. The next thing we looked at, so that was just Anglophones, Francophones. Next, we start looking at the language of the homes for long-term care residents. So Francophones, where did they reside? Well, let me see here. Let me make sure I got this right. So Francophones, a lot of them resided in designated homes, so French designated homes, but also a large proportion of them reside in non-designated homes. And it made a difference in terms of quality indicators by language groups in long-term care, if you're an Anglophone or Francophone, still very descriptive. So for example, I think Francophones had higher proportion of restraints. So they were put in physical restraints more often. Pain, they experienced pain a bit more and less so in other indicators. So it was quite mixed basically. But I'll show you where it starts to get interesting. So when we married those two concepts of being treated in a language concordant home or designated home versus not, and seeing how it impacts outcomes, we start seeing differences. So let's just look at only Francophones here. So Francophones again are the linguistic minorities. If it's in Quebec, obviously you might focus on Anglophones or other minority groups. And Francophones who resided in a non-designated home, so these are not homes that guarantee you that people can speak French to you. They had higher rates of antipsychotic medications, higher rates of depression, higher rates of pressure ulcers, higher rates of falls, and lower rates of pain. And we think maybe that's because they're not communicating their pain, just hypothesis generating. But you can start seeing here some initial differences in care outcomes. Okay, so Francophones in non-designated homes, by and large receive poor outcomes in long-term care homes. I'm not going to go through this, but it tells you the same thing. And here's the, okay, yeah, sorry, I'm going to move on, but that's long-term care. Any questions about that? We adjusted it and it became significant and all that stuff, but I thought I just showed the unadjusted rates here. Ben?
Can I just comment that it's interesting that the non-designated home francophones have numbers that are similar to the designated or non-designated anglophones. So I'm not sure what to make of that, but
it's messy with anglophones, huh? Like, because, you know, like everyone speaks English, obviously, technically, you know, and has proficiency. You know, we focus on the francophones and linguistic minorities, and, you know, there's some, what we notice is there are some home effects as well. So we have to be careful when we do these studies. So like francophone homes, and especially cultural homes like Chinese homes, Polish homes, Italian homes, it seems like the care they're providing is a little bit different.
yeah, maybe a bit better. Yeah.
But anyway, it's multi-level, huh? Let's just put it that way. And when we do these studies, we do a lot of multi-level stuff to account for, you know, home level, you know, geographic level. I'll show you COVID studies that are very interesting too. But you have, like, if you're doing COVID study, you have to control at the home level, you have to control at the region level, blah, 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 you know. But okay, I'm gonna skip over this, and that's just long. I'm gonna give you snippets, okay, if that's okay. And then the next thing we looked at was actually hospitals. So that's long-term care homes. That's it apply for hospitals. And this is, let me orient you here. So this is the adjusted relative risk, and the black bars here are English-speaking hospitals. Here are the bilingual, or the gray bars are the bilingual or designated homes. And you can tell that, you know, for francophones, you know, their rates obviously of, well, if we focus on minorities, their rates of harms. So this is, you know, remember those harms I talked about, like falls and pressure ulcers, medication errors. Their rates of these harms go down by 25%, okay, if they're in a French designated home. Sorry, French designated hospital in this case, okay? Allophones didn't seem to make a difference. And here's the home effect. I think it's Barry that you mentioned, that it seems like these homes, these hospitals are providing better care, quote unquote, to all individuals, right? But the effect is markedly more when it comes to francophones, right? So francophones who are receiving care in MOF4, they're experiencing lower rates of harms than if they were at the Ottawa Hospital, for example, or Toronto General Hospital. Ooh, okay, so again, we just keep on going and going and going. But the next thing we look at is people receiving home care. I'm going to skip over this. I'm just going to explain to you what the results show. So this is adjusted models, okay, for age, sex, multimorbidity, you know, the usual stuff. And we look at francophones and allophones who are receiving home care. So people residing in the community. And we looked at what are their rates of hospitalizations, readmissions, and repeat ED visits. And you can tell they're, you know, it seems like, you know, so this is the hazard ratio for people who are, let me get this. So this is for people who are getting discordant language. Oh yes, sorry, I'm getting confused here. We did so many studies, but this is looking at language concordance with their physician. So if you have a physician, like a family physician who speaks the same language as you, are your rates of hospitalization different than if your physician doesn't speak the same language? And in this case, if you receive language discordant care, your rates are slightly higher, but you can tell that they're hardly significant. So not huge, you know, hazard ratios, but, you know, obviously they're significant in some cases because of the large sort of the sample size that we have. So that was for physician care. And then I think this is where things really kind of become really significant. And this is the inpatient hospital outcomes of and this is getting to our SAM-HG study of francophones and allophones who are admitted under a physician who speaks the same language as you. So if you're a francophone and you get admitted in hospital, if the physician that's providing the majority of your care speaks French, we look at the differences in those inpatient harms length of stay, and death in hospital. And we did that for francophones and allophones. And here is where we use CPSO data, the College of Physicians and Surgeons of Ontario data, same as the last slide. So what we did is we link language of the provider, of the physician, which is collected by CPSO, into ICS, so we can see, okay, that physician billing for that or providing care in that hospitalization, did they speak the same language as the patient? And the language of the patient it's derived from the home care recipients, remember, from the RIDE data. And we asked us, does it make a difference in terms of these outcomes? So these are, I believe, unadjusted, okay? And it actually becomes a lot more significant when you adjust. But when you look at, let's look at allophones here. When you look at this inpatient harms, if you get a language discordant hospitalization, your rate of the inpatient hospital harm is 13%. So 13% of people admitted receive one of these harms: falls, infections, medication errors. If you are admitted and lucky you, the very few of you, your patient can speak the same language as you, so you're Chinese and you speak Chinese and your physician can speak Chinese, incredibly, your rate of inpatient hospital harms goes down to 3.6%. Okay, so a marked difference. And what's really interesting is, these other metrics, right? So you look at length of stay, 13.8 days and 10.4 days. So for whatever reason, it goes down as well. Mortality, 13.5%. So allophones who are admitted to a physician who does not speak their language, they have a 13.5% chance of dying. If that physician speaks your language, 6.7%. Okay, so we see some differences here, obviously, in francophones as well, but not as marked as allophones, right? Because allophones, a lot of francophones are bilingual, but allophones, by definition, are they're generally not bilingual or cannot speak English that well. Is that pretty clear? So those are pretty large effect sizes, huh? Yeah.
Are there any translation services, Peter, in any of the hospitals, or do you know?
There are, and that was a comment made by all the reviewers. This was our CMAJ paper, and we said that probably attenuates the results. That it probably squeezes the odds ratios less, right, to less, because we can't capture that. We don't know who's getting interpreter services, so there's misclassification there. But if you truly look at people who do not get interpreter services, I bet you the hazard ratio or the odds ratio are much higher.
Because that would be nice to be able to show, if you can somehow, in order, well, we need it for various issues here, so we'd like you to do that. Yeah,
and we always think about the so what, so what can you do about this, right? Well, there's several so whats. The biggest one is obviously interpreter services, obviously ensuring a diverse workforce, but how much can you actually do that? Even simple things like taking stock of the languages that your workforce speaks. Like, say you're in the ER or in a GIM, like, do you know what languages your nurses can speak? Well, maybe you do, if but to keep a actual, like, okay, we know nurse, Mr. Smith or Mrs. Smith, the nurse, can speak, Punjabi or Chinese, let's get them to help us translate, right? Even simple things like that, I think can help a little bit, right? But
I don't know if you know the new legislation here in Quebec, but anyway.
I do.
Yeah.
I know.
Yeah, which we've been fighting, but anyway, yeah.
I mean, we always, we wrote several grants after this, but it's kind of like, imagine you have available a pill, right, that can reduce your in-hospital mortality rate by 50%. Who's not going to do everything they can to make sure that pill is provided, right? Or if that pill increases your risk of dying by 50, by twofold, right? Who's not going to try to all their best to avoid that, right? And it's incredible. Like, when we saw these risks, we had to double, triple check it because we weren't expecting such high differences, and it held up, like we had to verify independently, but it held up. And I'm going to show you now this is adjusted models, right? And this is what got a lot of play in the media and things like that, okay? So inpatient hospital harms, okay, when adjusting for age, sex, multimorbidity, the whole shebang, neighborhood income quintile, that kind of stuff. So the adjusted odds ratio for francophones for inpatient harms is 0.63, so 37 lower odds. Look at that. Look at inpatient harms for allophones. It goes down by 75. Well, the odds ratio goes down by 75. I always get it. You know what I mean? It's remarkable, right? Length of stay, a little bit difference, not huge. Mortality, okay, it becomes even more marked. So for 56 lower odds, percent lower odds among allophones in terms of mortality if you get care from a physician that speaks the same language as you. It's remarkable, huh? Like we're not, obviously, observational data will always be hypothesis generating, but so what's leading to deaths? I mean, inpatient harms, I mean, you can easily see how this happens, and you just have to go to any MMRMs, and that lack of communication impacts bad things happening. But death, like, why is it, maybe it's some of those inpatient harms, but that's a huge decrease in mortality rate once if your physician, just your physician, not your nurses or anyone else, can speak the same language. Okay, I'm gonna pause there. I have some more slides, obviously, but I'm gonna talk for another 10 minutes after this. But any questions on this so far?
I have a couple of questions. This is, I mean, super important work. You've really motivated some of us locally to actually pursue this further. We looked really quick and dirty at our data warehouse and pulled the variables as the best we could to sort of conduct the same analyses in our hospitalized patients and see very consistent results. The magnitude is not as large, but the rigor with which the language spoken was determined was much poorer quality than what you've done. And so, as you mentioned, that would tend to bias things towards null. And so nevertheless, we have highly statistical results for in-hospital mortality and length of stay in the same direction as you're describing. So we're sort of pursuing a study to test whether on-demand translation services, which are not at all standard of care, in fact, are kind of actively discouraged or even, I mean, made illegal, to see if we can bend the needle. But I guess my question, though, comes down to how concerned are you about residual confounding?
Yeah, in the direction of that's.
Well, I guess what we see, again, this was a very quick and dirty analysis just to see if there was a remote signal that aligned with your data. Like I put all my faith in your data, and this was just, are we seeing something similar? And we do. Yeah. But we did notice by language spoken, meaning English or French versus other, pretty large differences in, say, age. And I don't know why that is. I don't know. I mean, but I just worry that, I don't even worry, but I just wonder about residual confounding. It's not stopping us from pursuing the sort of interventional study, but did you, in looking at your table 1, or probably the much more granular data that you have access to, do these groups differ in ways that maybe SCS or other things that might somehow be driving this?
Not crazily different. that's the bottom line. We have access to not only the basic stuff, age, sex, multimorbidity, but we have access to because it's home care data, right? So we have access to ADLs, IADLs, cognition, level of impairment. There's no crazy differences, and we adjust for those factors, and it just magnifies the difference. So I think well, in this population, sorry.
I mean, these are such huge differences. It's this seems like such an important thing to explore further. And anyways, it's just frustrating that the government is almost in opposition to this, even though, like you said, like this is, if you just focused on length of stay, this is like potentially cost savings. Not that that should be the motivation. Like,
No, for sure.
but
I mean, it obviously, yeah, go ahead.
No, I was wondering, Peter, if you could explain, so the language concordant allophone, so is that like so you had actually the languages that the physicians could speak, so,
Yeah.
like my family's originally from West Bengal, my parents, so it would be like a Bengali speaking physician as their second or third language. Okay, so all right, now that's interesting, because I'm just wondering if it were at the institutional level, which you talked about for the Francophone institutions, which is a little different from an individual physician in a regular institution. At an institutional level, could it be like the bilingual institutions? Like there's probably, like you were saying, more than the language. There's maybe being attuned to differences among people. And then similarly, language, there's culture, there's, attitudes, there's a lot going on there. I don't know
For
if you want to comment on that. Yeah.
Yeah, it's exactly. Those are exactly our thoughts. That it's not just language, it's culture. Like, I'm a palliative care. I work in palliative care, and like, try speaking about death and dying to someone who has a different culture as you. Good luck. Like, I think it's not just language, right? It's culture and nursing culture as well. And the language of the physician. I mean, I don't know if you're interested in this, but we did some work to group languages, like Portuguese, Spanish, you kind of understand each other, that kind of stuff. So we did that as well. Yeah, absolutely. So like the Francophones, like you saw the French designated homes, did better for allophones as well, right? So it could be the culture of the institution as well. And it's complex, but the nice thing about this is like it seems to all be going the right direction, like language to the home, language to the physician. Remember, we don't even account for language of nurses, for example, which may be even more important. I don't know, in nursing homes for sure, right? But in the hospital, maybe, right? And there's some misclassification there, right? Like physician cannot speak language, but nurse can, so there's I think if we were even more granular, we would see even bigger differences here. Yeah, and maybe what I can do is finish up the slides and then open up to discussion. I do have a few more slides which I think you'll find interesting as well. COVID, everyone's talking about COVID. I just like talking to the figures. So basically we look at long-term care homes, in nursing homes. Quebec, the same thing. Obviously, Ontario was hit hard in nursing homes, and a lot of our cases and deaths were in nursing homes, right? So this is allophones, anglophones, and francophones across the first year of the pandemic, essentially. And it's obviously very messy. So I'll show you the tabular format, which is easier to understand. But we looked at the trends of COVID infection rates, right? Across the pandemic waves, and you can see that, yeah, maybe there's the allophone, that there's allophones. You see the red line is generally pretty, higher. There's a lot of stochastic variation, but I'll show you here. And this is under review. Actually, we're just resubmitting it to CMAJ. But when you look at the overall results, it's pretty striking too. So here's all the homes, right? And we look at allophones, anglophones, and francophones. And this is frequency of COVID diagnosis. So out of all the residents that we looked at in a closed cohort, what proportion of them got COVID during our time period? And 22.5% of allophones contracted COVID, 13% anglophones, and 9% of francophones. Ginormous differences, right? And this is an institutional setting.
Sorry, by home, you mean this refers to a nursing home?
Yeah, sorry, nursing home. That's right, Ben. And sorry, I'm trying to just, what did I do? Okay, yeah, so, and then these are all the languages that, we looked at. And, based on, we create an algorithm based on the majority of residents who speak a particular language. We classified homes as being English homes, French homes, or, one of these ethnic homes, okay? So Chinese, Dutch, you can see Italian. So in Ontario, there's lots of these ethnic specific homes, not lots, but there are that cater to specific ethnicities, okay? And so again, just off the top, before looking at language concordance or anything like that, higher rates, we don't know why, of allophones, higher rates of COVID among allophones compared to francophones and not small difference, a huge difference, okay? And we also looked at outcomes. So this is where it gets pretty interesting as well. So allophones here, so you can tell that there's actually a much higher rate of hospitalizations among allophones. So higher infection rates, but also higher hospitalization rates like admissions and much higher rates of ED visits. But this is a cohort of people who get admitted, but once you're admitted, allophones have a lower chance of being admitted to the ICU and have a lower chance of being ventilated. So this is a different cohort here. Sorry, I know we mixed it up, but these two are among people who get admitted, and these two are among everyone. So differences in infection rates, which is our first our same issue that's under review, and then we're writing up this study as well, looking at differences in outcomes. So it looks like allophones are, and this speaks to the culture, perhaps, we don't know, but allophones generally want or are being sent to the hospital more, okay, when they get COVID compared to the other language groups, and not just a small difference, a huge difference. But obviously here, when you look at the francophones, admitted less often, but once they're admitted, they're hugely markedly at higher risk of being ventilated and being in the ICU. I hope that's clear, but
why do you think they're less likely to be hospitalized than the Anglophones? Is it a younger population, kind of like Ben was saying, or what's?
It's actually older. Like francophones are slightly older in long-term care homes. Not sure, like
because that's bizarre. Unless they had the capacity to look after them at the homes, maybe that was it that they were.
Yeah, we think some of it is cultural. Like there's this. I don't want to be stereotypical, but like among allophones, there's like in Chinese culture, you're supposed to get care in the hospital,
right?
Francophones, maybe there's a more laissez-faire, attitude, but at least in Ontario,
no, it is in Quebec too. Yeah.
About going to the hospital, right? And a lot of transfers are driven not only by medical decisions, but by pressure from families and blah, 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 right? So there's, I think, some cultural elements here, but, obviously big differences. I think, and, we're still very early. I mean, it's kind of crazy that, we're early in this program of research, because I don't know why people we should be looking at this, right? But what we're showing over and over again is that language matters, essentially, right? And in this case, language matters for COVID infection rates, language matters for COVID outcomes, right? Just to make it, since everyone's talking about COVID as well. I think that's all for the slides. There's 13 minutes left. I wanted to keep it short. I had bonus slides for what we did with our physician health data, but that's how we were able, but I'm not going to show them to you, but that's how we were able to figure out the language of the physicians, which is a game changer, essentially. We haven't gone to Quebec yet, but we're trying to do the same thing in BC, Alberta, Manitoba, and Nova Scotia, trying to replicate and import physician-based data, and then link it to the physician patient language, and then replicate similar studies, right, to make the case as well. Yeah. The other thing we're doing is actually linking in nursing data. So from the College of Nurses of Ontario, we're in negotiation with them. It's such a weird dance with these regulatory bodies, because that's not in their mandate to improve, to improve care necessarily. But anyways, but we're hoping to kind of import nursing language data as well to look at how that impacts outcomes as well. Mm-hmm. Okay, I'm going to stop sharing if that's okay. I think there's and then so that people, whoops, I start video. Stop share. And then if people, it's a small enough group that if you want to just jump in and ask questions or make comments, that'll be fine. And if we end earlier, that's fine too. Yeah.
That's, once again, really, really important work. The magnitude of these effects, there's clearly something important, I guess, unpacking mechanisms and how to intervene upon them, if they should be intervened upon, I guess is the hard and I guess also interesting and fun part. So there's praise coming in on the chat, thanking you for the impressive work. I guess I have a couple of questions in the meantime. So one question is, it sounds like we've talked about, in terms of mechanisms, notions of language, like communication and miscommunication.
Yeah.
We've talked about culture, like from the patient's perspective. Do you think there's, should we raise the specter of racism or sort of actual sort of differences in care provided from the healthcare providers' perspective? Like, are we not offering the ICU care that we should be offering to these patients who are showing up? Is that something that there's potential signals for, or that should be explored further, or you think that that's probably not it?
Yeah, I mean, it's a great question. I mean, there are a lot of studies from the US, right? Looking at disparities in outcomes among, I think the big study recently was among Black moms who were delivered by Black physicians, right? And how they, experience much better outcomes than if they were being delivered by a non-African American physician. Could it be systemic racism? I don't doubt it. I think like how much, we like to think in Canada less, but your guess is as best as mine. I think a lot of this, what we hope to do is, unpack some of this, through qualitative studies. Obviously, that's one of the main ways you can do this. But try to then, put in some other variables that we can look at to explore not just language, but ethnicity. So we have in Ontario, for example, access to Citizenship Immigration Canada data, for immigrants. So we're able to know who came from what country, not just language they spoke. But so we're starting to do studies, for example, then looking at, Francophones, but immigrants, for example, but Francophone immigrants who came from European countries versus African countries, right? Is it just about language, or is it about, everything else, right? And, to try to start getting at that, so there are some creative ways. I mean, health min data will always be limited in some ways. That's why we pair with other things, including interventional studies. But I mean, that's an obvious thing, right? Like Francophone immigrants are not all the same, refugees versus not Africa, from Europe, But your guess is as best as mine, but I don't doubt that there's differences there, right?
Yeah. Another thought I had, and yeah, raise your hand if you have a question, or just speak up and don't let me do all the talking. But looking at that last slide you had about sort of allophones, anglophones, francophones presenting to ED and getting hospitalized in that sort of dose response, and then seeing the inverse with respect to ICU admissions. I'm just wondering about, like, I suppose you could look at indices of the severity of illness at presentation. Like, is it that there's a tendency for people to show up more to the ER, with milder stages of disease in one language group, and to wait until you're quite severe in another language group? That might sort of explain that the few people, Francophones, that do show up are really quite ill and end up more likely in the ICU, whereas at the other extreme, many more are presenting, but there's less admissions. I don't know. Could be one of that.
Ben, if you want to work on with us on that, it's not written yet. So, and our analysis is not complete, but yeah,
we did look at that using our data warehouse with respect to not language, but looking at, are people showing up later for non-COVID related conditions during the pandemic, and we saw some interesting signals. But anyways, so yeah, I'll touch base with you, I guess, in relation to this interventional study looking at providing on-demand translations, or perhaps this is a good opportunity. Maybe we're so far behind in Quebec that this is an opportunity where we can actually test this, sort of randomizing people to on-demand translation services to see if we can actually move the needle, or is it something that isn't modifiable, sort of related to culture or other factors?
Yeah, it'll be interesting. Love to see what findings you have for sure. That's where we should be getting for sure, interventional studies after this.
Yeah. Okay. Well, sorry to interrupt your retreat. I hope, sounds like you're in a beautiful place, and I hope that you're having a great time.
No problem.
I think Satya has a comment there. Do you want to go ahead?
Yeah, hi, sorry, I'm an intruder. I actually just joined Peter's team, but I had been talking to colleagues in Quebec because I spent a lot of time at McGill and then just joined University of Ottawa. But I just wanted to react to a couple of points. Ben, your comment about kind of the inverse results, between hospitalization, admission versus ICU and ventilator, and your comment about, I mean, that this potentially being, about how care is provided, or, if possibly racism in the sense that, or misalignment with cultural preferences, right? Like that certain cultures are more likely to want interventions, so they present. But once you're in the hospital, the decision, is often driven by the care providers, right? So here we'll take you in, but we're less likely to give you the intensive care. I just, I think that's probably worth exploring. The other, general comment I wanted to make in terms of conversations I've had with colleagues in Quebec is just that I find it shocking that, given the circumstances in Quebec, that the language variable is not even there, like or is very difficult to get. Like the data is not there, but legislation is being made where there's absence of data. Like I find that really shocking.
There's many shocking things here.
Yeah. We do a lot of things in the absence of evidence. I think that's what we learn, right? Yeah.
No, but the policy is not evidence driven. That's the point. The question is, can evidence be used to counter it? That's the question.
Yeah. It's a 50% pill for death,
Yeah.
It's just, I mean, that's just incredible, right?
Yeah.
Mm-hmm. Can you, I couldn't find, oh, sorry, I'm in this, sorry, I was just giving a lecture and I'm in an empty classroom and I guess the lights go off automatically. So I'll try to wave my hands, but I am here, I promise. Can you, sorry, what my question was, I lost my train of thought. So we're proposing this study to randomize people to access to this literally 24/7 on-demand translation service or not. We're targeting, very much aligned with your CMAJ publication, a particularly high risk, or a group that might be particularly susceptible to communication barriers. So, people being admitted to internal medicine services. Do you have how does one define the level of language barrier? Do you have any thoughts on that? I mean, it's obviously a continuum. There's the language you speak at home is one index, but obviously you could easily be fluent in English or French at the same time. Is there any sort of guidance you could provide in that framework? Yeah, and I mean, there's linguistic experts that we on our team, Ben, that maybe I can connect you with. But essentially, there's crazy long tests, to examine your proficiencies, which is obviously not realistic. But there are simple tests, to understand, what's your level of proficiency. And I think I'll connect you offline to the linguist. Yeah, we partner with Department of Linguistics to figure that out. But the right variables, all the way that it was captured is basically the assessor sits there and assesses what language are they most comfortable talking in. And that's, that was good enough to show those differences. So if you're able to kind of just sit there and ask them what language would you prefer to converse in if you had a choice, I think that's not too bad of a proxy of how proficient they are. Yeah. I suspect, it distills down to something simple. You could probably spend hours with a questionnaire, but it's something simple like that. Okay, great. Well, thanks again. Really, really important work, I think. So keep it up and we'll be in touch. Yeah, happy to collaborate. We're very collaborative. So if you make headway, and just let me know. We're happy to share codes and all that stuff. It's no problem at all, programming codes. Yeah, thanks.